Dr. Tripathi, thank you very much. Great to see so many people. Wow, I'd almost say this is like the Super Bowl, right? There's as much excitement in the air. Maybe won't get as much attention, but I bet it's more consequential than yesterday's game. So thank you all for being here. And I don't know which team you might have rooted for, but if you rooted for the team that thought TEFCA could get done, then you put your money on the right place. So good for you. I want to say to Dr. Tripathi and all the people that have been part of this operation at HHS, but writ large, all of you who have participated, many of you are there, you're the superstars. One of you will get the most valuable player award, chances are, but all of you have had a role in making this very possible. And while most Americans probably won't recognize that you scored some real touchdowns in the last several months of work, at some point it's going to click that something has changed, that all of a sudden that specialist instantly got the information that was needed to keep you alive. And at some point the synapses will click and they'll realize something has changed in the way we do healthcare, and it's going to be to my benefit. And so again, while we may not get to see a whole bunch of money invested in commercials on what you're doing today, the way we saw with the Super Bowl, in so many ways, one, it was time, but two, it's a game changer. So congratulations to all of you for what you're doing. The President and the Vice President have made this a priority. This should have been done a while ago. And it's not easy. Everybody's got their own way of doing business, but we're doing it. And so to Mickey, to you and your team, on your watch, you could say that we took on this bear, and it is going to be a great benefit to so many people. So thank you, all of you who are participating in this effort. In the process of saying that he wanted to lower the cost of health care for a lot of Americans, most people probably didn't think that TEFCA was going to be part of that effort. But I think each and every one of us recognizes that this is one of the main ways, long term, that we're going to bring down the cost of health care for a lot of folks. I already told you how, and you know how we're going to save lives, but we're also going to bring down the cost of health care. And so that is obviously a good thing for everyone. This is going to benefit patients. It's going to support providers. It's going to be a boom in the end of the day for healthcare companies. But most importantly, for everyone who has some connection in the healthcare system to health and safety, this takes us to the next level. Part of what defines the 21st century digital healthcare system is interoperability. Healthcare interoperability is critical if we're going to talk healthcare national infrastructure. Interoperable health information technology improves patient care, enables better connection between patients and their providers. It helps reduce the risk of dangerous medical errors, and it ensures our country is prepared for any future public health care crisis. It does that by connecting doctors and patients to more complete and accurate health records, and by allowing patients to access their records, which combined allow patients and their providers to make smarter decisions about care. You probably noticed that my first set of remarks, Super Bowl and the rest, probably were not written. You probably noticed that what I just said is because I know you already know this. I'm going to cut my remarks brief because pretty much everything that's in my remarks you already know. Pretty much everything in my remarks reflects the work that you all have been doing. Here's what I want you to know as someone privileged to sit as the Secretary of the Department of Health and Human Services. You're going to get this done. You're actually going to figure out a way to connect people across the country, professionals, but patients as well. You're going to do something that should have been done years ago, and you're going to get it done soon. And you're doing it in collaboration, in a partnership that is actually working. I don't know about you, but if you take a look at government these days, that doesn't happen a whole lot. And so please take credit for what you have done. Please recognize the work that you did. Please understand that those who will be most grateful will never know you had a hand in keeping their loved one alive, but you did it. It's like all those unsung heroes in yesterday's Super Bowl. Yes, Mahomes got the MVP, but had there not been that block, had there not been that tackle, had there not been the interference created to let that runner go through, it would have been a different 38-35 score. And so someone is going to get that information on their brain tumor quicker to where it needs to go. Someone is not going to have the wrong medicine injected in their body. And you did that block. You know, you ran the interference. And so the unsung heroes are here today. And if I had time, I'd come up with a really good commercial that could really show what you all have done. I have the pleasure of getting to thank those who have done so much of the work in getting us ready. Certainly, I want to thank the Sequoia Project for being such an indispensable part of our team in helping make this happen. And I'm going to go straight to the folks that we should be recognizing. One of the things about TEFCA is that it's purely voluntary. The department was not given any funding to do this work. Congress, in its wisdom, decided to pass a law, but they didn't decide to have the money follow that new law. But thanks to the following 6 networks that I'm going to identify, we saw people step up. We saw them come forward, but more importantly, we saw them help build the network. It will get the work done and get it done soon. I know it took considerable effort just to get to this point that we're at today, to get through the different approval processes, but thank you all for your commitment. So let me begin to recognize each one of them one at a time, as well as our nonprofit partner, the Sequoia Project, because they're all helping make it happen and making your life easier and letting you score those touchdowns. If I can begin, and Chris is going to give us direction. Do you want me to, can I name all 6 of them first, and then we'll go ahead and come up and individually. This is almost like the MVP and the $20 million increase in your salary that you would get after, you know, winning the Super Bowl. So just sort of play with us on this. Remember, this is all voluntary. I will give you their names, and then we'll get them their precious award. Paul Wilder, the Executive Director of Commonwealth Health Alliance. Jay Nakashima, CEO of eHealth Exchange. Judy Faulkner, CEO of Epic. Steve Yaskin, CEO of Health Gorilla. John Elwell, CEO of No2. Laura McCrary, CEO of Kanza. And Marianne Yeager, CEO of the Sequoia Project. I would like to ask each of them to please come forward to receive their recognition. as some of these champions take their seat, I can just close by saying this. For a guy who loves data, a guy who believes that numbers can tell stories, for someone who, for the longest time, when I would ask, when I was a member of Congress for 24 years, could never get the data, and for a guy now who gets to sit at the Department of Health and Human Services and make sure that not only we get data, but we disaggregate it, we dispense it, we make it transparent, and we share it. What you're doing is, well, for me, it is a Super Bowl. It really does feel like something that I can sink my teeth into and believe in. Because if you want to make a difference, and I think we've all learned this, it's not the Hail Mary pass. It's the little things. And I got to tell you, to see how quickly you all came together, I remember when Mickey was first chatting with us about this and how we were going to try to build this together. And then when you throw the element in there of, by the way, we don't have the authority to require it, to demand it, and we don't have the money to sort of keep people coming back. But to see where we are, you got to believe in this stuff. And so something tells me you would be in those trenches regardless of what was at stake in terms of direct remuneration or benefit to you. And so that's the best of all worlds, is to win the prize knowing that you could have been doing something else. This is like your little hobby almost, but man, is it going to make a difference. So to each and every one of you for participating, please don't stop. We'll figure out some sugar or some treat to give you at some point in time. But please don't stop. Mickey is counting on you. I believe the team at ONC has taken us farther than anyone ever believed. Well, we want to cross the goal line, right? So help us cross that goal line. Help us save those lives. And when the stories come out on the evening news of someone who was miraculously saved, you savor that. Because that was you who opened that gap for that runner to take that football all the way down to the goal line and cross. That was you. And you get the credit. That's all I can give you, just credit. But thank you all very much. Continue forward. Mickey, I'm going to turn this show over to you all as you continue forward. We got some great folks who are going to be giving you further presentation. But thank you all for what you're doing. Know that at HHS, we're not going away. We're going to be there right with you. Thank you all.
Thank you so much, Mr. Secretary. Excuse me. And now Dr. Prabhakar will join us and speak from the White House. Thank you.
Thank you, Mickey, and thanks everyone for being here. I'm Arathi Prabhakar. I'm the Director of the Office of Science and Technology Policy and the President's Assistant for Science and Technology. And we sit over at the White House, not that far away, and among other things, we have the great pleasure and privilege of working with all of our colleagues here at HHS to achieve health outcomes, and one part of that is our cancer moonshot. So a lot of good efforts. Now, I'm really excited I get to be here today. One of my favorite things that President Biden says, and you heard it at the State of the Union last week if you listened to that, he talks about how America can be defined in a single word, and that word is possibilities. And so today I want to celebrate this amazing milestone that you all as a group have achieved, but I also want to look ahead to some of the bigger possibilities that it opens up. And you know, what's happening here today is a critically important step. If you think about the fact that we live in a world where I can watch money moving from one bank account to another from my smartphone, it really does make you wonder why we still aren't able to get our medical records around seamlessly. I was waiting for a medical appointment a few months ago, and a woman came in. She was a caretaker. She had an elderly relative in a wheelchair, and they had shown up for a medical appointment for a scan of some sort, and the young woman behind the counter, you know, very politely explained that they didn't have some piece of information that they needed for that to happen. And the caretaker just lost it, and I'm sure you all have seen this. And as painful as it was to watch that, it was something I think we can all sympathize with, because we know how easily information moves around in other parts of our lives. So why isn't it possible for it to happen here when it comes to medical information? Well, when I asked that question, the answer, there are some very real reasons that you all know and that you are now going to go grapple with in a very serious way. When you think about it, there's this word cloud of APIs and informed consent and HIPAA and FHIR, and there's so many other pieces to the puzzle because it is a very complex undertaking. And I really want to recognize that all of you coming together across companies, working with Mickey's organization here in HHS, this is really not a trivial undertaking, and it's one that's very, very significant. I think a great example of the big things that are possible when we do cut across those boundaries. So that's a great start. I know you have a lot more work to do to even make that seamless availability of records possible, but I want to take a minute and look ahead to what it enables, because to me this really is just the beginning. Because of course the first thing that happens when those kinds of that kind of data is widely available, some very important immediate things happen. One of them is simply the improvement in the care for that one individual because the information is available, and I think that's the obvious piece. But I want to look a little farther ahead. Rachel's going to be talking to us about what happens with public health. Some very significant advances are going to happen there. I also want to think with you for a minute about how we're going to be able to improve clinical trials. Think about how we can improve the ability to recruit patients for clinical trials, and then think about how we can improve the quality of the learning from those clinical trials, our ability to sort out what is and isn't happening, and to be able to see that in much closer to real world settings. I think those are going to be huge advances. And as we do that, what we will be doing is unlocking not just a better course of treatment for one individual, but we'll be starting to use the power of the data that's becoming available to unlock better courses of treatment for thousands and then ultimately for millions of people. And this, I think, really starts showing the power of scale that you all are now starting to unleash. Ultimately, what we are aiming for is the kind of deeper understanding that allows us to understand the sources of disease and start eliminating them. And I think that really starts to get at why this is such a big deal and why it's such a big moment today. So this is how we do big things across by working together across all of our different domains. If we're able to start this journey and start improving one patient's care, but then ultimately start changing the way health care and then ultimately health unfolds in America. If we're able to do this, we're going to be able to realize one of the most significant aspirations that we have as a country today, which is to improve health outcomes for every American, irrespective of gender, irrespective of sexual orientation, irrespective of race, ethnicity, or zip code. And I want to congratulate all of you for taking this first step on a long and very, very important journey. So with that, I now get to turn it back over to Mickey, who made all of this happen from his perch here, and I'll turn it back over to him to continue the program. Thank you so much.
Now you get me for a little while. Thank you to Secretary Becerra, Dr. Prabhakar, and Deputy Secretary Palm in absentia for their tremendous support. I'm privileged to run an agency under the leadership of President Biden, who encourages us to finish the job. under Secretary Becerra, who directs us in HHS always to never go mild, is the phrase he uses over and over again, never go mild. And Deputy Secretary Palm, who always stresses the importance of building cross-agency muscle, as she calls it, so that the department and the government at large is more than the sum of its parts. Our work in TEFCA reflects all of this and more. Before I start, let me thank the ONC and Sequoia Project teams who've worked diligently for years to get us to this moment. Let me also thank members of my team who planned this event, which was like planning a wedding and a bar mitzvah and a quinceañera all at once, and in a federal office building. Mitch Cost, Avery Royston, Jean Kaplan, Matt Swain, the team from OKU, and many, many others, they attended to every painstaking detail so that we can all be here today and recognize this moment. A nationwide interoperability network has been part of the ONC vision since our founding in 2004. The NWIN, or Nationwide Health Information Network, was an ONC launch network for nationwide health information exchange. In fact, some of that history is here today. Marianne Yeager ran the NWIN and helped guide this transition to the private sector, where it eventually became the Health Exchange. Where's Jay? There's Jay. That is one of the organizations represented here today. It was an uphill fight, though, because we had a big problem. The vast majority of providers didn't have electronic health records. It was like trying to build a telephone network before most people had telephones. The HITECH Act, of course, provided an answer to that and allowed Medicare and Medicaid to invest in the healthcare delivery system by incentivizing the adoption of electronic health records. It was an enormous undertaking that spanned a decade, but we're now at the point that 97% of hospitals and 90% of physician offices across the country use electronic health records. As part of the HITECH Act, ONC also provided HIE funding to every state, an investment in basic and applied research that offered many, many lessons for industry. Multiple networks, both big and small, started blossoming, and the nationwide network problem rapidly shifted to aligning and connecting networks that were forming from the ground up, the network of networks problem that we want to solve today. The private sector made significant and very meaningful progress in interoperability, and I would argue that it hasn't gotten nearly enough recognition or credit for what it did accomplish. For example, tens of millions of medical record transactions occur every day under care equality, tens of millions per day, a level that's similar to the scale of the daily transaction volume of the SWIFT global banking network. However, there are still big gaps, and it's increasingly obvious that filling those gaps is going to require more active and coordinated public-private collaboration because the private sector can't tackle all these issues on its own. So what are those gaps? First, there's a digital divide. For example, something like a quarter, maybe 30% of hospitals in the country aren't connected to a nationwide network due to lack of financial resources, technical capacity, and frankly, market confusion. Not knowing where they should connect. There's this network, there's that network, there's a local network, there's multiple state nationwide networks. Where should I invest the limited time and the resources that I have? Many of those are in rural settings, which also serve a high number of veterans. And Dr. Elnahal is here to speak to the importance of interoperability to our veterans. Second gap, public health agencies don't participate in nationwide interoperability today. Even in the throes of a devastating pandemic, very few public health agencies were able to access health exchange networks to get reliable, accurate, real-time information from providers, let alone being able to share information with each other or with the CDC. And on the provider side of the equation, the administrative burden of having separate, unique data feeds and data use agreements for each public health program and each jurisdiction across the country poses a huge barrier to high-quality, actionable public health data. Dr. Rochelle Walensky is here to discuss the tremendous work she's leading at the CDC to rectify that, in part by leveraging TEFCA. A third gap in network interoperability is information sharing between payers and providers to streamline medical documentation requirements, healthcare operations, and care management. The types of payer-provider exchanges have been, these types of payer-provider exchanges have been effectively shut out of existing networks because of competitive issues between payers and providers. It's an extraordinary hidden tax on our system because it means that neither payers nor providers have access to the data they need to be able to improve the quality and efficiency of healthcare. It's also led to a bewildering jumble of custom, costly, and often manual arrangements between each payer and provider that adds layers of cost and headache to providers, payers, and patients. TEFCA sets up a mechanism for payers to more easily get clinical data that they need to streamline approvals and payment, and for providers to get claims data that they need to better manage care and reduce redundant care, as called for in CMS's most recent draft interoperability rule. John Blum is here from CMS to describe the truly innovative work that CMS is doing to further interoperability and the role that TEFCA may play in that work. Another gap that industry hasn't been able to fill is to make it easier for patients to access their own information without special effort, as the 21st Century Cures Act calls for. TEFCA provides pathways for patient access through, for patients to access their information through a single application of their choice, regardless of where that information is. Of course, privacy and security are major areas of concern in all aspects, but certainly with patients directly accessing their information. So we've also added provisions in TEFCA that require that vendors who provide such services, who are most often not covered by HIPAA or regulated by HIPAA, we've added provisions that those vendors are required to meet the requirements of the HIPAA privacy and security rules, and in some cases go beyond those rules to give patients more control and visibility into what's happening with their data once it leaves the protection of HIPAA-regulated entities. None of these gaps are easy to address, and TEFCA won't solve them overnight. However, we've grown to accept these and many other gaps in operational friction and interoperability because so many of them can't be resolved without really meaningful public-private partnership. But we shouldn't do that anymore. Our vision is that TEFCA can get us out of this collective learned helplessness that we're in with some of these things and address head-on these and many other issues that prevent forward progress that are important to all of us. So let's talk explicitly about TEFCA. The 21st Century Cures Act of 2016, signed by President Obama with strong bipartisan support in both chambers of Congress, directed ONC to establish a public-private approach to address our growing network of networks issue. The goal is that, like wireless networks and electricity grids and ATMs, as we've already talked about, our user experience should be as if it's a single network. Healthcare is much more complicated, however, because it's so fragmented and has inherently complex and dynamic data and literally has life or death consequences if we get it wrong. So creating and connecting networks takes a lot more than the set it and forget it type of approach that works in other industries. The goal of TEFCA is to establish a uniform floor of baseline of health data interoperability across the country. Its core infrastructure for the healthcare delivery system, like electricity or broadband or water, so that patients and those involved in their care at the individual and population levels can focus more on delivering the best possible care and less on trying to pry data loose from resistant systems. TEFCA Exchange is not a big database of records. It's a set of policies and technologies that allow organizations and individuals to more efficiently share information with each other. It's also not an open door to medical records. TEFCA doesn't allow anything more than is already allowed by applicable federal, state, and local law. It just makes it easier to do so safely and securely and efficiently. Upon coming into office in January 2021, we took the work done during the previous administration, and I want to recognize Genevieve Morris, who was here at ONC at the time and is here today and led much of that work. We took that work and we did a number of things to make it ready for prime time. We accelerated it and established firm goals and timelines to give the market certainty and predictability about the government's intentions and plans. We aligned it with best practices of networks today to ensure a smooth glide path to TEFCA Exchange. We bolstered the approach to cybersecurity management and oversight, which we all know is a growing menace in the healthcare industry. Finally, we adapted the approach to not only support older exchange standards, but also to advance new standards, namely FHIR APIs, which the industry has embraced and are key elements of ONC and CMS interoperability regulations, as well as CDC and VA programs. Last year, within 12 months of coming into office, we published the TEFCA Data Sharing Agreement, known as the Common Agreement, and the Technical Specifications Framework. And here we are today, just over 12 months after that, announcing 6 networks who are stepping forward to help implement the TEFCA vision. We're going to work really hard to help these networks begin sharing information with each other via TEFCA for treatment and individual access, as they've all committed to within 12 months. And hopefully, even by the end of 2023, as the Secretary was going to say to you, but then he went off script. But let me convey to the Secretary that he really wanted to encourage all of you to do it in 2023, not take the full 12 months. This spring, This spring, we're going to release the standard operating procedures for public health and for payment and healthcare operations, and we're working actively now to recruit public health and payer early adopters for these critical use cases to implement them in 2024. If it feels like we're moving really fast, that's only because we are. We're at a unique moment in time. The dust is finally settled after the hard work of establishing a digital foundation of medical records. And the architects of the 21st century digital healthcare system are already hard at work building on top of that foundation. As the vestiges of paper-based processes start to give way to new processes based on natively digital information flows and processes, we hope that TEFCA can be a way to ensure that patients directly reap the benefits of everything that digital innovation has to offer. Let me now yield the stage to Dr. Rochelle Walensky, the Director of the Centers for Disease Control and Prevention, to talk about public health.
Thank you, Mickey. It is really a pleasure to be here with you today to celebrate this historic milestone and to highlight the organizations which have voluntarily stepped forward to meet the demanding TEFCA eligibility requirements. I think that was Mickey's cue for me to stay on script, but I am going to just quickly say that I come here with the great privilege of serving as the CDC director, but I also come with a 25-year clinical background. So I do want to say, as enthusiastic as I am about this for CDC and for public health, I am equally enthusiastic for my fellow clinicians who are going to reap the benefits of these successes. The broad attention paid to public health as a result of the COVID-19 pandemic, including the public's seemingly insatiable need and appetite for data, has made it very clear that we must modernize our public health data and information systems, and we have to do it now. We can't do the basic work of public health without monitoring case and laboratory reports of communicable diseases, without receiving data on who is dying and why, without receiving data from emergency rooms to track the earliest signs of that first Mpox case or that first hepatitis case in our community, and understanding the extent of the chronic diseases that affect our nation's health and take too many lives every single day. We have to have a nationwide approach to public health interoperability that gets our state, local, tribal, and territorial and federal public health professionals the data that they need when they need it. And we must take the data that's available as quickly as possible from our healthcare providers, for our healthcare providers who are working on the front lines every single day, for the policymakers to feed it back to the state, local, tribal, territorial, and federal levels, and for the public. Every day, as Mickey noted, millions of health records flow through nationwide interoperability networks, yet most public health agencies have no access. It's a missed opportunity and one that we at CDC recognize. I cannot tell you, having been in this job for now 25 months, how frustrating it is to be in this position, and it may be true for many of you as well, when you know the data exist that could help you make a better decision, and you don't have access to them because of poor data flow, because the systems aren't compatible. We are all better off when our data systems are better, when we have a modern data system and the public health workforce to feed it. At CDC, we've launched critical initiatives like CDC Moving Forward, the Data Modernization Initiative, and our North Star architecture to bridge the gaps in our national data infrastructure system, initiatives that will bring modern, scalable, and responsive technical and management approaches to public health data. We can work better together as partners if public health is more directly integrated with the healthcare system. Receiving the heavy burden that reporting places, or reducing, I should say, the heavy burden that reporting places on providers so that they can spend more time with patients on patient care. One system told me they saved 140,000 hours of person time. And likewise, allowing those in state and local health departments to focus on interventions that, rather than doing data entry, focus on protecting public health. The cost of our current way of operating, both in time and in dollars, is just far too high. We're spending too much time reinventing the wheel, negotiating data use agreements, building interfaces, and establishing security. And that work is ongoing even as we speak to try and improve our data systems. We often have records that are missing or incomplete. We lack a shared governance for our public health systems and our public health data. We shoulder too many costs in making different point-to-point connections, for example, with clinical data sources or between states or between counties within a given state. And too much effort is spent on recruiting and onboarding new data sources. But this network can help. It gives us common rules of the road for data sharing, for use and governance, a common posture on cybersecurity, helps us be more transparent, and guides public health participation in the critical infrastructure that we will all rely on. Providers will be able to share information on public health using the same infrastructure they use to share information with each other for clinical care. Just imagine. Public health agencies, I'm so excited. I really am. Public health agencies will be able to share information back to providers, and to state, local, tribal, and territorial jurisdictions can share information with each other for important tasks like case investigation. And very importantly, patients will have modern apps to directly send to and receive information from not only their healthcare providers, but their public health agencies. It's an exciting future to think about. TEFCA presents us an opportunity and a means to advance towards our strategic objectives and accelerate nationwide connectivity in ways we have never had it before. CDC and ONC are working with state, tribal, local, and territorial communities to identify early adopters and to help forge the path so that the whole public health community can see how much there is to benefit from TEFCA and all that there is to offer. As a federated architecture, TEFCA offers the flexibility to accommodate state and local policies and authorities around public health, while allowing all jurisdictions to benefit from the common rules of the road and the technical infrastructure. And while there is so much work that we have ahead, and we recognize that, we are ready to do it. We are excited to do it. So I really want to just thank all of you for being with us on this journey. I am so looking forward to our charting together a course forward. Thank you very much, and I'm now delighted to turn the podium to John Blum from CMS. Thank you.
First and foremost, I want to thank you for joining us today. I want to thank Mickey and his team for being such great partners to CMS. But one thing that I learned last week, that CMS right now is the biggest producer of data that goes to the cloud within the federal government. And so for any payer like CMS, that is our core work, producing data. And so we can think about data as helping to facilitate transactions, the healthcare visit, the healthcare service that was delivered. Or we can think about healthcare being that journey. Healthcare patients today don't have transactions, they have journeys. Those that go through life, they change health plans, turning 65, having disability. Those that get married or that change their job. So we at CMS, or we in the overall payer communities, can think of our roles as just simply helping to facilitate transactions, or we can think about really helping people change lives and helping to promote better journeys for care. People, patients, don't see one physician. They don't see one healthcare provider. They don't see one ACO. They see many, many physicians. People will change coverage through time, through life, that we have to support. So for CMS, we will do everything that we can to ensure that we are helping to support your work. I want to take 3 examples. We are moving towards better quality metrics that will not only just promote more transactions, check the box, but to really change healthcare outcomes. We are taking away friction burden that comes with continuous prior authorizations. People don't need to go through the scary process year after year with physicians fighting physicians to get better coverage. We are changing that. The third example is that we want to see a world where there is one healthcare directory, that we don't have to continuously chase physicians to get data, to get information, but kind of one common network. All 3 of those pieces, better quality metrics, reduce friction, more shared data through the provider directories, that will happen through TEFCA. So we want to thank Mickey and his team for helping to really support CMS work. And CMS going forward will build that stronger muscle to use our authorities to ensure that your work really bears fruit. So at CMS, we pledge to work with ONC really hand in hand. We also really pledge to use CMS tools to help support however we can to support your work. So with that, I want to thank everybody here. I want to thank Mickey and his team, and turn the floor to Sharif with the VA.
Good morning, everybody. Want to thank the Secretary and Dr. Tripathi for inviting us here today at a VA. We consider this to be a very veteran-centric effort. You are not only setting the foundation, the 6 organizations being announced today for QHIN, not only setting the foundation for American healthcare, you are doing so for the millions of veterans who wore the cloth of this country to defend our freedom and who are now getting care under our system and outside of our system. In the spirit of Secretary Becerra's comments earlier, Secretary McDonough's request that we always keep the veteran at the center of everything we do, and the President's remarks in the State of the Union that again talk about possibilities. Imagine the possibilities in the future for American veterans because of your work. Imagine a veteran who's at risk of dying by suicide, shows up in crisis to an emergency room. And we are able to send a signal directly to the point of care, serving that veteran, that we will cover the costs of that visit, we will cover the costs of residential care, inpatient care, and care for up to 90 days in the outpatient setting, because that veteran was at risk for suicide, no matter whether they're enrolled in the VA or not. The President and the Secretary announced that groundbreaking policy just a month ago. How many veterans know about it, and do they know about it when they need to? This will enable that work. Imagine that veteran showing up for follow-up in a community provider setting for a different issue. And that provider is alerted to that veteran's history and risk for suicide and is able to connect that veteran with the right care, whether it's in VA or outside of VA, because they are alerted to do so with the right system and with the right connectivity across the American healthcare system. Imagine a veteran showing up for care anywhere in the country and endorsing that they have respiratory conditions, possibly from burn pit exposure from their service in Iraq. If we're able to alert and trigger that provider to be aware of the historic legislation that President Biden signed on August 10th of last year, that the VA is now finally there for veterans exposed to toxins across multiple conflicts, that we are finally able to provide that care or pay for that care in the community for the first time. That could be a life-saving move for that veteran. That is what is possible with the work that you're all contributing to today. And finally, I have no choice in a system that serves 9 million veterans but to think like a public health professional. And we take maddeningly too long to get updated on suicide data. It takes 2 years right now to do that. Dr. Walensky and I have had these conversations. Imagine if we were able to get that data in real time, or a month lag, or a quarter lag. Imagine if we're able to get overdose deaths for veterans and the general population in a way that doesn't require us to manually get information from death certificates across the country and wait for that data to be uploaded in system after system to the CDC and then to us for veterans. This is game-changing work that ultimately will reach patients and veterans across the country. And so we've seen the use case for this for many years at VA, alongside our partners at CMS and DoD. And Dr. Blum spoke to some of this. We've pioneered the blue button, which actually for the first time gave veterans access to their own healthcare information on their smartphone. Had they had a consistent vector to bring it to that community provider, or even to another spot within our own system, admittedly, to be able to port that data in seamlessly, that would have gone so much further. That work happened in 2010. This is the chance to accelerate the potential of that groundbreaking work. And right now, we pay for about 33% of our care that we provide to veterans in the community. We rely on you as provider systems, on EHR vendors to help us get that information back and forth through interoperability where we can. And that has everything to do with our ability to provide high-quality care to veterans everywhere. With our Lighthouse initiative, we've embraced FHIR APIs, as has this initiative, for clinical-facing applications. And we are a ready partner and an anchor participant in the eHealth Exchange, which is now one of the largest public-private health information networks in the country. And in 2020, we expanded a joint HIE with our system, the Department of Defense, the Coast Guard, and now the Commonwealth Health Alliance, one of the recognized parties today. That is a nationwide network of 15,000 hospitals and clinics. And there is so much more that is possible to connect to the rest of the American healthcare system. So Dr. Tripathi, this work is really groundbreaking for veterans everywhere, to include the possibility of helping the hardest to reach veterans in rural areas. Veterans are disproportionately living in rural areas, and it is our responsibility as VA and as the federal government and as an American healthcare system to be able to connect even the most poorly resourced providers in the country to a network of health exchange for the first time. That is the potential of this work, and I am so glad that VA is part of it on behalf of the brave women and men who've served this country. With that, I will now give the floor to the QHIN Roundtable, and thank you so much.
All right, well, thank you all so much for coming today and to helping us celebrate really an incredible milestone. And I just also want to thank the Secretary and ONC and Mickey in particular for hosting this event and for the incredible leaders for joining us today. It sort of reinforces, we always believe TEFCA is important, but it's pretty incredible to see that it resonates as well with so many. I also want to take a moment to just acknowledge that Sequoia is supremely honored to work with ONC to develop and now implement TEFCA. And we really appreciate the confidence that you all have placed in us on this journey. And I would be remiss if I also didn't recognize the rock star team we have working on this project. I think most of whom are here, and just, I've never worked with such an incredible group, and so I just want to acknowledge them and everything that they've done today. So first, then I want to say congratulations.
Thank you.
Yeah,
Thank you.
Thank you for taking the leap of faith with us. I would like to say things were 100% baked when we started opening up the application process, but we were sort of adapting as we went along, and I just couldn't think of a better group to help us work through that process, so thank you. So why don't we start, and just start with some perspectives that you all have. I mean, I think folks have acknowledged the incredible progress we've realized in the private sector, and I'm just curious, from where you sit, you all went through a very contemplative process to really embark on this. And so what do you see TEFCA accomplishing that the private sector endeavors have really not been able to do to date? So sort of what value does TEFCA have?
I'm supposed to turn it on, make sure it's on. I don't see it as an or statement. I see it as it's a substantiation of what needs to happen. It's been the missing piece. I think Dr. Tripathi mentioned it was the uniform floor that's not been there, and thus the private sector couldn't really make the progress that they've needed to. So I think it's an and, it's critical. It's the power grid. It's like trying to build a city without the power grid. So I see it as a and statement and really, really important.
Do you want to introduce yourself and your organization?
Sure. I'm Troy Sabelli, I said as the founder of No2, and very honored to be here, especially with these fine group of people. So thank you very much.
Matt Doyle. I'm on the development team at Epic, who has built a lot of our interoperability tools over the years. And I think that one of the great opportunities is to build on top of what the private sector has done and really bring a partnership between the public and private sector together. There's been a lot of great success stories. When we look around the private sector today, interoperability has been a success over many years. There have been a lot of great success stories. Our community exchanges 11 million patient charts every single day. Half of that is with other vendor platforms, with our federal partners like DoD, VA. That's possible in large part not just because of what vendors have done, but also because of what Care Equality has done. Care Equality is one of the great success stories of healthcare interoperability so far. Today, 70% of hospitals are live exchanging health information in real time in support of treatment. Now that's a wonderful success story, but coming back to your question, there's still a gap. That means that a large number of hospitals are on the sidelines. And I think that TEFCA's big opportunity is to encourage those folks to come off the interoperability sidelines, to join, to build on the success that we've seen before, and TEFCA can help to set that expectation nationwide.
So, excuse me, Dave Castle. I'm SVP of Customer Success and Operations at Health Gorilla. I would certainly agree with what Teresa and Matt have said, but I would also think that everything we just heard, and all of the folks speaking from the various government agencies will state their case more eloquently than I can summarize here, so I'll let their statements stand. But that ability to partner with the federal government is huge. It opens up so many additional opportunities for us to see value that the private sector alone hasn't been able to achieve. I think there's also an opportunity for federal incentives to play a huge role in tapping into that additional 30%, as well as helping enable some of these other use cases that were spoken about. But in order to enable that type of collaboration, we also had to raise the floor, raise the bar a little bit. And all of us up here have gone through a rigorous process already. The journey's not complete. There's more to come, but already been a rigorous process just to be part of this. And raising the bar on trust, which encompasses security, it encompasses the operational governance, it encompasses policy level governance. Raising that bar, I think, is what gives the federal agencies the level of comfort that they need in order to really dive in fully and bring that level of success that I think we'll see with TEFCA.
Well, thank you very much. My name's Laura McCrary. I'm the president and CEO of the Kansa National Network, and I appreciate the opportunity just to share a little bit about why TEFCA and becoming a QHIN is so important to us. We are a 501c3 not-for-profit organization. We were incorporated in 2010 in Kansas, which you all can see I'm wearing my red for Go Chiefs. And so very happy at the outcome last night of the Super Bowl, as you might imagine. But no, really, we are at our core mission. We are providing services to providers, to patients, and to the payers that really work with all of us every single day. And so to that end, I have my board chair with me here today who represents really the people that we do this work for, Dr. Joe Davison, a primary care practicing physician in Wichita, Kansas, helps us remember every single day the reason that we're here and the reason that the QHIN model and TEFCA is so important is to really be able to make sure that patients get the safest care and providers have the longitudinal information that they need to be able to provide that care. So Kansa provides health information exchange services across the nation. We partner with medical societies in 9 states to really make sure that providers have that information, whether it's in Connecticut or New Jersey or in Mississippi or in Louisiana, whether they're urban or rural providers. These are the individuals who really need to benefit from the work that we're doing here today. We've been at it for a long time. 15 years for my team is how long we've been working on this. And today, when we sit up here, the opportunity to really think about what's going to happen is amazing. And I just thank everybody who's in this room for the work that you've done to actually get us here. So thank you, and we're excited about what the future holds.
All right, Jay Nakashima with eHealth Exchange, and I'm going to leave poor Paul here with nothing left to say.
I'll figure out something.
Yeah, he always comes up with something. You know, at eHealth Exchange, I think we're super excited about the promise of new use cases. So like Matt said, you know, we're exchanging billions, if not trillions of transactions a year for treatment, which is fantastic for clinicians at the bedside or tableside or chairside. But above and beyond that, there's a strong need for exchange for other purposes of use. So for healthcare operations, for payment, for research, for public health, you know, right after a major pandemic. So we are super excited about expanding into those markets. And also we're thrilled about another opportunity to surface or exchange data from state and regional HIEs who historically have been the backbone of interoperability across the US. So there's a lot more to come, and we'll see what happens over the coming months and years.
Well, it is a little harder going last, I will say that. So actually the most important thing that I bring, first of all, from Commonwealth, Paul Wilder, Executive Director there. We've been in existence about 10 years. We're about to celebrate our 10-year anniversary this March, actually. So HIMSS will be an interesting party this year. You know, we connect a lot of the country. So it's about 30,000 clinical sites. You look at some of the antecedents to TEFCA, we think of care quality, 50,000. And I think the most important thing that we sometimes forget day to day is how much we still don't have connected. We mentioned 70% of the hospitals, 30% is a lot to be missing, right? We got to fix that. If you think in clinical sites, though, look up the data. It's about 210,000 clinical sites in the country. We've connected 50,000. That's a lot more to go. And I point to, Mickey mentioned about, it's a brand thing, right? The confusion. I don't think those who are in this room are confused about what to do interop. There's a lot of other practices that are. And it creates more of a verb and a noun at the same time when someone can say to their vendor, are you connected to TEFCA? And they'll say, I'm not, but the thing ahead of you is, whatever QHIN it is, we got you covered. So that program that comes out, when the VAs talk to them and saying, hey, we're on TEFCA, how do we make sure we can interoperate? That it's easier to know that the endpoints are there, as opposed to thinking, what do I have, what do they have? And we're doing a very good job right now, but it is hard to advance use cases. And I think this effort is likely to move us there at a much, much more swift pace than we've done in the past, with a brand identity of TEFCA to help us get there. So proud to be here and excited to be with everybody else to make this work.
Well, that's fantastic. So I've spoken with each of you at different times or much earlier in the process and had a much more blunt way of putting this, but I'll be more PC today. So why why do you want to be a QHIN? So maybe, Paul, do you want to go first?
We get there first. I had to go first. It's actually a very simple answer. We couldn't imagine not being one, right? So, again, formed 10 years ago, and we were a bunch of vendors, big vendors. You look at market shares, like, oh my God, there's a big network. And other care quality came right after. Full homage to eHealth Exchange and NWHIN Healthy Way before that. There was a lot of work done, but we knew there was more to do, right? There's still more to do. And I think we could have gotten pretty far doing what we're doing, but you did start to see, you see like adoption curve, and you see a little bit of plateau hitting. You go, how do we get to the next level? It often requires a little bit of a leap. Something's got to kick you up to that next tier to get the remaining, 70%. We talk 70% of the hospitals, back to the same numbers. 75% still left to go. And you'll hear from HHS, from CMS, from, pick the agency underneath, health equity. And I think the ultimate health equity is that the small solo doc provider in North Dakota who does half of his care to someone's home flying there in a biplane, right, should still be able to get to access to the same data that a large hospital system does, right? It's not fair to the person living out there that they're not connected. Wasn't their choice for it not to get all the way down to the final mile to their home. And so we have more work to do. And I think this network, this framework, allows us to take that next leap. High security, high participation from the federal government, along with a private partnership with all the stuff that's already happened before. For us, it was kind of an obvious choice, right? There was no way we could not participate to advance this cause. So, on behalf of myself and the board, we're all in. We're all in the day this got announced 6 years ago, and we'll be all in for the next 6 years as we build and improve it and thereon. So, thrilled to be here.
Yeah, so eHealth Exchange is one of the first, obviously, to sign on to the TEFCA framework, and it's for a variety of reasons. I think TEFCA's done a really nice job of tightening interoperability, both from a trust perspective as well as from a technical specifications perspective. So we're hoping that we become a little closer to, dare I say it, plug and play. Of course, there will be no plugging and there'll be no playing, but we'll be a little bit closer to it. Above and beyond that, we want our participants to have a broader community with whom to exchange. So we want our federal agencies, the FDA, Indian Health Service, VA, DOD, to be able to exchange with more healthcare organizations across the U.S. And then the same goes for the state and regional HIEs. So today, off the top of my head, here in the audience, we have CRISP that operates in 5 states. We have Sync Health that operates in 2 states, Manifest Medics, and many others. And we want to make sure that their communities are represented and can exchange. I think finally it's public health, and that's the one that we are most excited about, is to really make that data flow to where it needs to be so that the public health authorities can make the decisions they need to make based on data.
Thanks, Jay. As I mentioned earlier, Kansa is a not-for-profit 501c3, and we have a mission to actually provide the very best and safest care that we can to patients and to make sure that our providers have the information that they need to do this. And so consequently, it wasn't really a question for us if we were going to become a QHIN, because that's part of our mission. I've said before, and some of you have heard me say this, healthcare is local until it's not. And when a mom takes her children to Florida, to Disney World, and the child gets hurt or the child gets sick, their medical records need to be available to the doctor who's in Florida. And the information about that child's medications, the information about the child's problems need to be there in a concise and complete way. And so what we have in front of us today is the opportunity for us to continue to move forward and achieve on our mission, which is to ensure that that mom does have the information there, the doctor has the information there, the child has the information, and we are able to provide the safest and most coordinated health care that we possibly can. So for us, again, it wasn't really a question. It was part of our mission, and we're honored and thrilled to be here today to continue with this work.
Yeah, I'll continue the trend. I think we saw it really as being central to our mission as well, of providing actionable, organized healthcare data where needed. I think we saw a real opportunity as well around what I spoke about earlier, this unlock of additional use cases, additional opportunities to collaborate with federal agencies, which in turn is going to open up additional private sector opportunities, I think, as well, as the federal agencies are able to lead the way. So all of that together, combined with the fact that our customers are simply beating down our doors, almost literally, to get an opportunity to do something beyond that treatment use case that again, it's a wonderful thing that we've seen it be enabled to the extent that it has. But we do need to advance the ball beyond doing treatment while continuing to chip away at that 30%. And that really was the opportunity that we saw to continue to advance our mission in this trusted infrastructure.
I've been doing interoperability for quite a while, and on the Care Everywhere team, we have a pretty simple mantra: to get the right information to the right person at the right time. And I think that's true regardless of what vendor system they're using, regardless of what technology is there. The reality is that we're all patients. We all receive healthcare at multiple venues. We go from our doctor to a specialist to the hospital, back to our doctor. It's important that that information is available to us anywhere we go. That's why we created Care Everywhere. That's been live for 15 years. 100% of the hospitals and clinics using Epic participate. That's why we first connected with our federal trading partners back in 2011, the VA, the DoD, the SSA. That's why we have been a strong supporter of care equality since it began in 2016. That's why we supported the creation of FHIR APIs so that patients can get access to their own information. Patients can use an app on their phone to get their information, connect it to their portal, and pull information onto that app and control that information, who has access to it. They can use it how they'd like. So we've always been all about interoperability. It's in our DNA. And that's why we're supporting TEFCA, because this is the opportunity to broaden to more participants, to broaden to more use cases, and to, again, make sure that the right information gets to the right person at the right time.
So we're going to tell a little story here. So 12 years ago, when the company was started, we took on the pillar in the company that we would go after parts of the market that nobody had gone after. And that was to go after post-acute, which is now, you can now call it pre-acute. We went after EMS, behavioral, dental, vision, social, and knowing that as the movie played forward, we would see those become the most important parts of healthcare. And we're seeing that now. We're seeing that play out. And we today represent the communication backend for the vast majority of those EHRs that serve those markets. We've been their loudest voice in those markets and will continue to be their loudest voice, especially as we look at the year 2030, which happens to be a magic year for a lot of things. But 2030 is the year that our baby boomers, every one of them will be over the age of 65. And we also have, first time in our country's history, we'll have more seniors than we have children in this country. And serving that market, serving the market as care moves to the home, and we got to get our cost out of care. That is our focus. That is our focus. We owe it. So why did we become a QHIN? You know, not to be antagonistic, but what else was there? This is it. And we could see that this is the foundation and the floor that's needed to change how this country, the trajectory we're on, and really, you know, change the outlook here for healthcare. And we believe fundamentally to our core, and to use your word, DNA, that this is the movement forward.
So you're gonna love this. I'm going totally off script. It's okay. No, what I mean, it's interesting. So I like to say that to move a market, you need market movers. And you know, we are in the business of interoperability. So because TEFCA exists, is great. It can fill a gap and be, provide a mechanism to facilitate all these things. But the next step is, how do you get people to use it? And how do you bring folks who have not been at the table to participate in these new use cases? So I'm really curious. I mean, you don't have to name names, but we think about who are the market movers we need to invite into this process? If we want to support payment and healthcare operations, Who do we need at the table? If we're going to support better, access for public health, who do we need at the table? So you think about that, and I'm just kind of curious what your thoughts are on sort of, the concept of needing market movers to create an impetus to exchange.
You handed me the microphone. So I guess I have to go first.
Sorry.
No, that's no apology needed. I agree with you. What we have to do is reach critical mass. When we think about how do we get interoperability to work, you have to get everyone involved. An analogy I like to think about is if I was the first person to invent a telephone and I'm the only person in the world with a telephone, it's completely meaningless. The only way it works is that everyone in your community has one. And interoperability is the same game. So how do we get everybody involved? I think while technology is important, and we've done a lot there and we'll continue to do a lot, the big challenge that I see is we have to bring everyone in and we have to build trust. We have to build faith in the system. We have to have transparency so that everyone understands my health information, which is very personal to me, which I care a lot about, and I'm willing to bet everyone in the audience is the same. I know who's going to have access to it. I know how it's going to be protected. I know everything that will happen and in what circumstances it will be shared. One of the great things that I think ONC and Sequoia have done is built into the rules of this that third-party apps who aren't HIPAA-covered entities still have to follow the HIPAA privacy and security rules. And that's one great example of how you build trust in from the beginning so that we can get market movers in. Now, in addition to that, I think folks like us who are going to become QHINs really need to go to our communities and we need to build up, drum up excitement. We need to help people understand how this is going to help them, how this is going to help their patients, how this is going to help public health, how this is going to help us as a nation to be stronger and better at healthcare.
Yeah, I'll riff off of Matt there. I agree with him completely. And ultimately, if you think about where healthcare data resides, where it's collected, it is with providers. The provider organizations are the ones that we need to convince through a combination of value, a combination of trustability, security, commitment to privacy, and ability to really secure that privacy, that it is safe for provider organizations to participate beyond treatment, where they've gotten, I think, a level of comfort for the most part, into these other use cases. The providers are still going to be the key. We need to bring payers to the table. We need to bring public health to the table. They're necessary but not sufficient. It's ultimately tapping into that information that really is collected through the course of care that all of these other players need for their various use cases. We need to find a way to bring the providers along.
I might mention the FHIR roadmap, the TEFCA FHIR roadmap. To my surprise, there seem to be a number of organizations out there, including payers, who have really been waiting on the sidelines until there's a more modern way to exchange data. So I see a number of healthcare organizations saying, hey, as soon as the FHIR roadmap is live and in production, that's when I'm going to engage and begin to exchange data. They don't want to do it the old SOAP web-based services way. So stay tuned for a number of organizations coming on board when that happens.
Yeah, I mean, we all agree that providers are the center, the start of everything. Getting payers, public health, very important. I think sometimes we forget there's administrative clinical flows that attach here as well. Like we forget, it's the right data at the right time, at the right clinician for the right patient. All that stuff is very true from the treatment side. A lot of the other use cases are administrative tasks that distract you from being a good provider, right? The provider doesn't go to medical school and 5 years of residency to operate a fax machine, right? That was probably not on the list of things they learned. Whether they had to dial 9 or a 9-1 or whatever to get, that's not what they wanted to learn when they got there. And they came out, and that's probably the first thing they had to learn as an administrative thing to do was how to exchange records, how to respond to life insurance requests. We talk about public health, sending things there back and forth. We owe it to them to do a better job. And so if they show up, the providers show up and say, I need help, and it's not just clinical, right? Get rid of the abrasion, get rid of all the administrative tasks, so I can move on and do what I really wanted to do, why I went to med school in the first place. It wasn't to send various quality things to payers, and let them get it easier so you can move on. They're going to get it anyway. So why get in the way and send 4,000 faxes and have a copier machine show up in a truck behind your office and photocopy this stuff when the button just works? And what you see, interestingly, is when you get like a payer and a good-sized provider that understands this whole problem, it flows pretty quick, right? So we need to get more examples out there showing that this does work, that it is safe. It's better for the practice, better for the patient, and better for all sides. We have to get better at crossing, what I call crossing the Ps. Providers, patients, public health, and payers, right? Whenever we cross those Ps, it gets harder. And we're getting a little bit better at it. The provider has got to come first, because the other use cases don't work without them there.
So I agree. I think that obviously the providers, the most important party, providers, patients, and payers are the most important parties here. I tend to think that our focus to the actual health technology vendor that's implementing the APIs is the most important part, because I don't think providers are resistant to change. They just don't make it hard. They don't want to have to think about it. They don't want to have to absorb a new workflow because it doesn't fit. It's an adjunct to what they did yesterday. It's up to the HIT vendors, or what we call the edge, to implement better. And our focus as a QHIN is to educate our edges on how do you do better workflows? What do you do to absorb this back into the clinical workflow so they don't have to think about it? They don't have to realize that there's a change needed, and they can push through it, and it's part of that. So I think the change that we need, and where maybe historically we've misstepped, has been the lack of coordination with the HIT vendors. We look at like what Care Quality did, and I'll use Epic as an example. Epic, sitting at the table, was able to implement workflows that work, that providers can use, and that has to be true across the industry. We have to see that across the industry with whatever the edge technology is, EHR vendors, digital health, patient engagement platforms. It just has to work. It has to be behind the scenes. I always say when interoperability moves from being a noun to a verb, we've done our job and we've implemented it.
And I'll kind of conclude this by saying, whenever our team goes into work with a hospital or with a new ambulatory practice or a federally qualified health center, the very first thing they ask is, how can we help you be more effective and efficient in the work that you're doing? How can we reduce the burden that you have of having to get medical records over your lunch hour, or be able to spend time in the evening calling specialty care providers so that you can get the medical records that you need for the patients that are scheduled in the next day. So our job is to make it easier for the providers that we work with, and that's really what we've got to think about. We don't want to create a new system that makes it harder for providers, or more difficult, or more confusion. And that's what the real hope up here is today, is that by working together and creating a system that is seamless for the provider community and for patients and for payers, that we actually solve some of the problems that over the few years that we've been doing this, we've created. So hopefully we continue to really focus on, let's ask our providers, let's ask patients, let's ask the payers, what can we do to help you be able to provide care more safely and more efficiently?
So we only have 3 minutes. Again, I'm still off script, so. Okay, think of this. One sentence closing that you would like to impart on this group. So I'll start. I think for TEFCA, I believe for TEFCA to be successful, we have to be supremely practical. And that means, starting simply, stepwise. And so that's my parting statement. Who would like to go next? Don't you love when I throw this out?
Yeah, I would say we need to focus on trust. Make sure that the public trusts the framework, and we'll be in good shape.
Communication. We have a bunch of folks here on the stage who have already announced our interest in making this work. The more we can work together, the more we can talk together, the more we can coordinate as we build and bring TEFCA live, the faster we're going to get there. You get there faster as a group.
I would agree with that. I would say, to reiterate, trust. The security and the privacy is going to build the trust that then will allow for there to be participation and then ultimately incentivization to help close all those gaps.
Yeah, it's one word for me. Excuse me, teamwork. Right, we just had all these analogies, Super Bowl, and it doesn't work if you don't have a team on the field. And in this case, it's kind of we're the league, right? We're all going to compete. We're all going to try to be better QHINs. That's great. But in the end, we have to have a set of rules, and the common agreement gives us that, to have a reason to be out and play every Sunday, to kick some rear, but also get this done. So it's really about teamwork.
Well, I like all the Kansas City analogies. I appreciate that. I would say, and my team will smile back there because I say this often, let's not let perfect be the enemy of good. We have the opportunity here now to really be able to create something that is going to be really, it's going to change healthcare from now on and moving forward. And we want to get to perfect, but right now we really need to get to good so that when that mom does show up in Florida and needs care for her child, that we can get the medical records there. So let's really focus on being good, and we'll get to perfect then.
This is going to be profound. Ditto. Let's do it.
All right, well, thank you all so much for joining us today. Again, congratulations on meeting this milestone, and we'll turn it over to Mickey to close us out.
Well, thanks so much to all of you for stepping forward. I hope that all of you in the last hour and a half have gotten a full appreciation that this is really a big day. And it's not just because this is the first time that you've seen me wear a tie. It's really a big day for interoperability. It is the beginning of the beginning. We know that there's a ton of work ahead. So what are the next immediate steps, just for everyone's awareness? The fact that we now have 6 organizations who have stepped forward, I think moves us into a new mode. We know who providers can talk to now. We know who participants can talk to now to start talking about implementation, start talking about the kinds of things that they want to be able to do to be able to move forward. I also would say that this is not a model that is static in the sense that it's only 6. We don't really have a number in mind for the number of QHINs. And so those who are thinking about becoming QHINs, please keep considering it. The model, the idea of the model is that it's a rolling model and that networks form organically according to a set of business principles, a set of business drivers, and those who want to get together and do this, we welcome them. So this is the first 6. They're forging the path for everyone else. And again, I want to just extend congratulations to all of you. Thank all of you. Let's give them all a round of applause, please. And we look forward to seeing all of you at the Go Live event. Thank you very much.